treatment-resistant depression, or TRD, is already, well, one of medicine's most frustrating challenges.
Absolutely.
But when you layer that over the unique complexities of the aging brain, specifically older adults or individuals already struggling with neurodegenerative conditions like Alzheimer's disease, it becomes, frankly, a massive crisis for treatment providers.
Yeah, a huge hurdle. Traditional therapies, the ones, built on that monoamine hypothesis, they often fail this incredibly high-need population.
And that failure, that's really the jumping off point for the systematic review we're diving into today, isn't it?
That failure is the critical starting point. Those conventional monoaminergic therapies, your SSRIs and SNRIs, they fall short precisely because, well, neurodegenerative changes fundamentally impact the baseline state of neurotransmitter systems and receptor dynamics in older compromised brains.
So the pathways they rely on are basically damaged or just dysfunctional.
Exactly. Which renders the old tools largely ineffective for getting, sustainable relief.
Okay, let's unpack this deep dive then. Our mission is pretty laser-focused, finding novel therapeutic avenues.
Right.
This particular review gathered sources up to January 2025, specifically looking at NMDA receptor antagonists, primarily ketamine. We need to uncover if ketamine and its emerging derivatives, esketamine and arketamine, offer a genuine effective path forward.
Yeah, for these really complex patients who might have few, if any, remaining options.
We are specifically looking for evidence of a breakthrough, something that kind of sidesteps the limitations of conventional psychiatry, especially with neurodegeneration involved.
Precisely.
And that context is, well, it's brutal. You're emphasizing that late-life depression combined with TRD and then overlaid with pathology like AD. That's where standard treatments just completely break down.
Yes. And what's fascinating here is the shift in the mechanism of action. Ketamine and its family, they work by antagonizing the NMDA receptor. And the preclinical data gathered in the review suggested a really powerful insight. Ketamine might hold a significant advantage over another existing NMDA antagonist already used in AD management, memantine.
Hold on. Tell us more about that comparison. If both are NMDA antagonists, why would ketamine potentially be superior?
Well, memantine is generally thought to be quite targeted in its action. But the hypothesis, supported by the preclinical work, is that ketamine's benefit comes from its broader mechanism of action.
Broader how?
It doesn't just block the receptor. It seems to rapidly induce neuroplastic changes, promoting synapse growth, restoring connectivity, which is exactly what an aging or AD-affected brain needs, perhaps more globally than memantine can achieve.
So we're talking about a treatment that doesn't just balance chemicals, but actively rebuilds or maybe restores damaged circuits. That sounds like a huge difference.
If a fundamentally different approach, potentially.
Okay, what was the scope of the evidence you looked at to, confidently draw this contrast? How solid is this?
It was rigorous. We followed the PRISMA guidelines, synthesized findings from 19 human clinical studies and 8 preclinical studies.
Yeah.
So it's a robust, multi-layered foundation of evidence we're exploring.
Got it. 19 human studies, 8 preclinical. That's substantial. Before we get to the results, let's quickly define the family members, because they do get confused sometimes.
Certainly. So you've got ketamine, the original compound, often given intravenously, 4B.
Right.
Then there's esketamine, which is the S-enantiomer, that's approved by the FDA and EMA back in 2019 as an add-on treatment for TRD, usually given as a nasal spray.
Okay, the nasal spray one.
And finally, arketamine, or R-ketamine. That's the other enantiomer. And it's currently emerging as a really promising alternative, possibly with fewer psychotomimetic side effects, the dissociative ones.
Interesting. Okay, let's get to the aha moment, the actual clinical results. Did this new mechanism actually translate into rapid and robust relief for these vulnerable patients?
It absolutely did. The findings consistently showed rapid and robust antidepressant effects in both AD patients and general older adults with TRD.
Rapid and robust, that's key.
Yes, it indicated a real potential to intervene quickly in conditions often marked by just long, drawn-out suffering.
Was there a clear, effective dose established? Because, dosing in older adults is always a bit tricky.
Yeah, the review helped narrow that down quite a bit. Clinical studies pointed to intravenous doses of 0.2 milligrams per kilogram or higher being significantly more effective than midazolam.
Midazolam. That's a typical active placebo, right?
Yeah.
Why is that comparison important for you, the listener?
That's right. Midazolam is an important comparator because it causes sedative effects, kind of similar to ketamine. This helps ensure that participants and clinicians are truly blinded, that they don't know who got what.
Ah, so it helps rule out just the experience of getting a drug.
Yes, exactly. By showing ketamine is significantly better than a sedative that mimics some effects, it really strengthens the argument that the benefit is genuine and pharmacological, not just placebo driven by getting any powerful drug. And the data suggested that 0.5 milligrams per kilogram for Bafi seems like a promising initial target dose for late-life TRD.
Okay, zero point 0.5 milligram kilograms. Now, here's the crucial test, I think. Often a drug performs well in younger TRD populations, but then fails when it hits geriatric patients because of all the physiological changes. Did the effectiveness hold up across these age groups?
This is where it gets really interesting and honestly provides a major confidence boost for the geriatric field.
Okay.
One comparative study looked at 36 geriatric patients defined as age 60 and older against 55 non-geriatric patients. Using the patient-reported BDI-2 scores, which measure depressive symptom severity, 4-meliketamine was found to be equally effective in both populations with TRD.
Wow. Equally effective. That's massive. It suggests a parity in efficacy, meaning the drug is somehow overcoming those age-related differences in metabolism or brain pathology, at least initially.
Precisely. The mechanism appears robust enough to, well, transcend the differences between those two groups.
Okay, let's talk about benefits beyond just mood scores. Were there any surprising non-mood related functional gains? Because for someone struggling with AD or even just general cognitive decline, an improvement in function is arguably even more vital than just lowering a depression score.
That's a phenomenal point, and yes, the review highlighted significant findings here. A 2023 study focusing on 25 older adults showed that repeated IV ketamine infusions led to improvement in both depression and executive function.
Executive function, that's things like planning, focus, remembering instructions, right? How significant was this cognitive recovery?
Well, after the continuation phase of the treatment, 48% of those participants achieved a positive response that's defined as a 50% or greater reduction in their MEDR score, the depression scale.
Almost half responded well on depression.
Yes, but the dual benefit, the mood and the cognitive lift, suggests a really profound impact on quality of life. It's moving beyond just symptom management.
So they aren't just feeling better, they might be able to do more and think better too.
Absolutely. And further studies supported this. A younger subset of geriatric patients, aged 65 to 74, showed improved depressive symptoms compared to the placebo group who were also taking their AD medication.
Okay.
And a large case series, this one involving 53 older adults, showed clinically significant improvements in 58% of participants. Importantly, the overall response and remission rates were comparable to what you typically see in the broader adult TRD population.
That consistency across different small studies really strengthens the signal, doesn't it?
It does. It suggests this isn't just a fluke finding.
Let's pivot slightly to synergy. If ketamine works differently, could it maybe enhance existing older treatments? I'm specifically thinking about electroconvulsive therapy, ECT.
Yeah, that connection was explicitly explored in the review. In geriatric patients, combining ketamine with ECT showed some notable advantages.
Like what?
Well, when used as the anesthetic agent during ECT, ketamine actually prolonged the duration of the convulsions.
Wait, why is prolonging the convulsion a good thing in ECT? Isn't the goal just to trigger a therapeutic seizure?
It sounds counterintuitive, but the duration of the seizure activity is actually linked to the overall therapeutic efficacy in ECT. So by using ketamine, you might be making the existing ECT treatment more potent, more effective.
Oh, okay.
And this combination led to more rapid and sustained improvements in depressive symptoms. This was shown vividly in case reports of older patients, including folks aged 80 and 69.
So it's potentially turning an old, effective tool into a better, maybe more efficient one.
It seems like it.
Mm-hmm.
There was one specific case mentioned, a 74-year-old woman with severe depression and dementia. When her anesthesia was switched to S-ketamine combined with ECT, she exhibited a complete resolution of her catatonic symptoms and a really marked enhancement in mood. It suggested the combination achieved a synergistic antidepressant effect that the conventional anesthesia couldn't match.
Wow, complete resolution. That's impressive. Okay, let's move from these macro results down to the micro mechanisms. What did the neurological correlates reveal about what that highly effective 0.5 millikilogram dose was actually doing to the brain networks? This is where we kind of eavesdrop on the brain's activity.
Yeah, the Leaf-Aid study provided a fantastic window into this. They found that the zero point 0.5 milligram dose wasn't just linked to high response rates, it was tied to a tangible effect on cortical excitation inhibition balance, or EI balance.
Okay, and for our listener, what is EI balance and why does it matter for depression?
Right, think of the brain like an orchestra. The EI balance is basically the ratio of signals promoting activity excitation versus signals quieting things down inhibition. In many mood disorders, this balance gets thrown off.
Okay.
Ketamine appears to rapidly restore a healthier balance. And we saw clear neurological evidence. There was increased frontal gamma power and decreased posterior alpha power during the infusion itself.
Okay, let's break that down. Increased frontal gamma power. What does that signify? What's happening there?
Gamma waves are the fastest brainwave oscillations. They're often associated with higher level processing, focus concentration, efficient information transfer. So increased gamma power in the frontal region suggests enhanced cognitive control and processing. Essentially, the brain is kind of kicking into a higher functioning gear.
Okay, more focused processing up front. And conversely, decreased posterior alpha power. What's that about?
Alpha waves are slower. They're usually linked to a more restful, unfocused, or kind of idling state. So decreased posterior alpha power during the infusion indicates reduced idling and likely increased resource allocation toward active processing.
Which fits with the improvements in executive function you mentioned earlier.
Exactly. It's a clear signal that the drug is actively changing how the brain networks communicate and in a way that promotes organized active function.
That gives us a really beautiful, comprehensive picture. Rapid effects, functional gains, parity across age groups, even a clear neurological correlate. But now for the crucial caveat. Because with any powerful intervention, we have to confront the long-term outlook. We can't just offer rapid relief. We need sustainable wellness.
This is absolutely critical context for the listener. While the rapid results are undeniably promising, the long-term effectiveness, well, it remains a major unresolved question.
How so?
The systematic review specifically cited a small study, only 6 patients aged 65 and older with TRD. Now, 4 out of those 6 experienced an initial improvement, which is good, but they were unable to sustain it during the maintenance phase.
Oof, that's a significant failure rate for maintenance, 4 out of 6. Why did the authors suspect the benefit was so transient in this specific older population? Are the neuroplastic changes just rapid but not permanent?
The authors of that particular study concluded that while ketamine can offer immediate relief, it may have limited long-term effectiveness in this older group. Perhaps because the underlying neurodegenerative pathology requires continuous or maybe more aggressive intervention to maintain those restored connections.
Ah.
It suggests the rebuilding effect might need ongoing support. It doesn't just stick on its own against that backdrop.
So the challenge really shifts from inducing relief to sustaining it. And this highlights a fundamental research need, refining treatment guidelines not just for the initial infusion, but for the maintenance period afterward, whether that means booster doses, other medications, maybe a different derivative entirely.
Exactly. We seem to know the key to unlocking the rapid effect, but the key to locking it in long term. That's still missing, especially for this group.
So what does this all mean for the future of treatment? If we synthesize this deep dive, ketamine and its derivatives offer rapid, robust relief for a population of older adults and AD patients with TRD who desperately need novel options. That seems clear.
Yeah.
We saw efficacy parity with younger adults, which is huge, and even these dramatic functional gains like improved executive function.
And the evidence points strongly toward ketamine's potential superiority over more localized NMDA antagonists like memantine. The data really argues that the field needs to maybe stop focusing so narrowly on single chemical imbalances and start exploring ketamine's broader mechanism of action, its ability to promote this widespread neuroplasticity to better understand and treat depression when it's intertwined with neurodegeneration.
That broader influence, that's really the key takeaway here, isn't it? Which leads us to our final provocative thought for you, the listener. If a drug's effectiveness for depression is fundamentally tied to its global influence on the brain's complex pathways, its ability to maybe rebuild connectivity, especially in aging populations, what does this tell us about the need to perhaps shift mental health treatment entirely? Should we be moving away from seeking single chemical targets and instead prioritize therapies that directly promote neuroplasticity and aim to restore the entire circuitry of the mind? Something for you to mull over as this research continues to develop.